Hi, I'm Nancy Lindell, Public and Media Relations at Mission Health, and I'm here today with our Chief Medical Officer, Dr. William Hathaway, to talk about COVID. Let's talk today. One of the top subjects in the news lately has been that we've had a handful of staff who have tested positive for COVID.
Yeah, we have had a handful of staff that have tested positive for COVID. About a week ago tomorrow, we had a few staff members on our pulmonary unit come down with some symptoms. And so I think people are well aware that we are actively screening all of our employees for symptoms of cough, shortness of breath, and fever in particular, but also other symptoms including loss of taste, loss of smell, nausea, diarrhea. Those are the major screening symptoms I want everyone to be aware of. And some staff members came down with symptoms, and so as we do typically, we isolated them, took them out of work. They were not at work at the time that they came down with their symptoms, and they were tested, some through their private doctors, some through our employee health. And at the end of the day, we found out that 6 of our employees had tested positive for COVID-19.
And how many more, I assume that unit was tested because of their proximity to those positive cases. So how many of those were tested and what were the results of that?
Yeah, we immediately shifted into a containment and definition and tracing mode. We wanted to make sure that there wasn't widespread of the illness on that unit, and we wanted to find out as best we could who had the illness, and we wanted to make sure that the unit itself was cleaned as best it could so that we would prevent further spread, if any spread. So at the end of the day, we tested all the people on that unit, and of the 55 to 60 tests, all the remaining tests were negative. We were grateful for that. We did contact tracing to determine if any of the patients had come into contact with the staff members in an unprotected fashion, and that didn't happen, so we're grateful for that. Nancy, I think that one of the most important lessons that we've learned from this is that if this illness can affect some of our most highly trained, most highly educated staff members who are most attentive to the use of personal protective equipment and are constantly on guard to protect themselves and their fellow colleagues and their patients, if they can get the illness while working together, then I think that's a warning to all of us that we can also be in a situation where we inadvertently transmit the disease. And so it's really critical that we pay attention to our own personal habits, wearing masks, waiting 6 feet apart, and washing our hands diligently to prevent transmission of the disease.
And I think that sort of leads naturally into our next question, which is that while we are in phase 2 in our area of opening back up, there are mask restrictions being put in place, and people are maybe feeling a little bit more bold, like, well, this hasn't happened to me and it's not going to happen to me. I think that people have that attitude, when they're smoking or speeding, they think, well, that's not going to happen to me, so it's okay for me to do it. How would you address that with the public to say, from a medical standpoint, what do we need to continue to do to keep the curve flat?
Well, I think let's start with masks. Let's go through the 3 W's. So wearing a mask, the most important part about wearing a mask is, frankly, that you're showing respect to your fellow man. The mask, while it does afford you some protection from getting the illness, really what it does is it prevents you from inadvertently shedding the virus and causing someone else to get infected. What we've learned is that many people can be in a pre-symptomatic or asymptomatic phase of the illness and can spread the disease without knowing it. So by wearing a mask, you're saying to your fellow man, I care about you, you're important to me, and I don't want you to get sick. So it's not about fear of getting the virus, it's about respect and showing other people that you don't want them to get the virus. The second part of the 3 W's, of course, is the waiting 6 feet apart. We know that if you do have the virus and you're spreading it in your respiratory secretions, there's a limited distance by which it can go, okay? And so the farther apart we are from each other, the lower, as our distance demonstrates today, the lower the likelihood that you're going to share the illness. So it's really critical that we don't overcrowd. When we're indoors, we limit the number of people in a gathering. When we're outdoors, we limit the number and we stay as far apart as possible. And then the washing the hands, this is critical, and I think it goes well beyond COVID-19, but our attentiveness to hand hygiene is critical for limiting the number of common cold and other kind of viral illnesses that we can get in our daily lives.
Even though we have not seen the cases that we thought we might at the hospital. Are we still prepared? I mean, what if this phased reopening causes that surge that we were looking for or thinking might occur at the beginning?
Yeah, well, right now we have about 10 or 11 patients in-house with COVID. Over the first 2 months of the illness, we were seeing on average 2 to 4 patients. So we have seen a significant, although not large, I think there's a real increase in the number of patients in the hospital. But those 10 patients come nowhere near close to impairing our capacity to care for both COVID and non-COVID illness right now. We have plenty of space, we have plenty of ventilators, we have plenty of ICU rooms, and we have ample protective equipment to do so. Does that mean we will tomorrow or the next day or the next day? We don't know. We hope so. That's why it's important that we continue to try to flatten the curve, but we monitor that every day and we adjust how we carry our operations on at the hospital according to what we see in the community.
And we've had an increase in our inpatient based on some of the positives that have occurred at the local assisted living centers.
Yeah, that's right. Early on in the course of the illness, here in Western North Carolina, Henderson County, which has a population which is less than half of that of Buncombe County, had a higher incidence of disease because, unfortunately for them, they were unlucky and it got into their nursing home population. The problem with the nursing homes and assisted living facilities, the skilled nursing facilities and assisted living facilities, is twofold. One, people are living together in a very densely congregated area, close to each other, often sharing meals, and for that reason there's easy transmissibility of disease through droplets. So they're close together. The second problem for the nursing homes, of course, is that these are people who are frail and elderly and often have lots of comorbidities. That's the fancy word for lots of other illnesses: high blood pressure, lung disease, heart disease, neurologic disease with prior strokes. And all of those other illnesses put them at risk for higher complications and worse outcomes related to COVID. So Henderson County had an onset prior to Buncombe County. Well, Buncombe County has caught up. This last week we've had a variety of different facilities that have experienced COVID-19. One of the facilities had over half of its residents who were affected and 30 or more of its employees. It was really a very tragic and difficult situation for them and for everybody. They did a spectacular job of managing it once it got into their facility. They did a great job of both caring for their staff who was caring for the patients and for the patients themselves. And they managed to only have one of the patients admitted to the hospital. Now, we did see some of the staff members admitted to the hospital, and they, for the most part, did well.
A lot of people have been concerned about our visitation policy. People are rightly so looking at their family members in the hospital, unable to come and see them, unable to participate in the rounding or the, what's going on with my mom or my dad, and being able to contribute, as family members often do, to letting you know, hey, this is what's bothering them, or don't forget they're taking this medication. And I know there's a lot of frustration out there. So can you talk to people about why we're continuing that and what efforts we're making to help people better still be able to communicate with their family member?
Sure. I think that the visitation policy and the restrictions that we put in place has been, participating in making that decision has been one of the most difficult things we've had to do. The last thing we want is a rampant illness brought into the hospital and have our staff members taken out so that they can't care for patients. That would be terrible. And we certainly don't want a patient to come into the hospital without the illness and then get it while they're in the hospital. And so we've limited and continue to limit visitor restrictions. As we have, and we evaluate it every day, and we base it on the prevalence of the disease in the community. We think the disease is increasing in our community, so it makes me very apprehensive right now to consider reducing the restrictions. We've brought in a series of iPads to the different floors so that family members can FaceTime their loved ones and at least have some kind of connection, but no one pretends that it's the same, and we all recognize the difficulty it is for families. We have allowed people who are having same-day surgeries to have visitors accompany them. We do allow pediatric patients, of course, to have moms and dads with them, and we allow laboring women to have a partner with them during the course of their labor. And then with select circumstances around end of life or patients who have dementia and other care needs, we'll will allow visitors there. We try to individualize it in those unique circumstances. I think it's important that we send a hearty thank you to the community for understanding the challenges of this policy. We are grateful that we have had community members who understand the reasons that we're doing this.
And you were talking about comorbidities and how that affects people who get coronavirus and the severity of their illness. However, that also seems to be negatively affecting people who are having serious medical issues from coming to the hospital for fear of getting COVID-19. And I know we've talked about this before, but I don't think that point can be driven home enough. And especially in light of our staff positives, talk to the community about the safety of coming to the hospital.
Yeah, I've said this before and I've reiterated it, that the hospital is a very safe place to come and get care, whether it's for COVID-19 or coronary artery disease or lung disease, or whether you're having a baby. We are expert in trying to isolate and protect patients and staff from infectious diseases. We have for years and years and years had protocols and procedures and policies in place that we both practice and implement on a regular basis to protect patients. And the risk, while it's not zero, of getting the illness while you're at the hospital is very, very, very low. And the risk of not getting your health care delivered if you're having a heart attack or a stroke or any other type of an illness that's serious or potentially life-threatening far outweighs the risk of that you'll get from potentially getting COVID if you come to the hospital. So I've said it in previous conversations that we've had, we implore people to come get the care they need. And that goes beyond the hospital, it goes to the office setting too. We want people to get their diagnostic screening tests. We want people to get their office visits. We especially want mothers to bring their children in for their vaccinations. We've seen a dip in the vaccination rates, and that gives me great pause going forward. We want to make sure that kids in that age group where vaccines are required are not falling behind on their vaccination rates.
So can you tell us a little bit, I know a lot of people have been reading in the paper about potential therapies and vaccines for COVID. What can you tell us about that?
Well, a lot, as a matter of fact, so I'll try to keep my points brief and to the point. With respect to therapies, I think it's really critical that people realize we don't have any proven therapies at this point in time. There has been one drug that's shown some promise. It's a drug called remdesivir, and it's an intravenous therapy, means you can only get it when you're in the hospital. And it was originally used, interestingly, for Ebola. We had reason to believe that it would have antiviral activity against COVID, just like the Ebola, it does against Ebola. And one study suggested that it reduced the duration of symptoms and had a suggestion of a mortality benefit for patients. And so right now that therapy is undergoing extensive trials all around the country to prove that it actually works. When we do a test or when we have a new drug for a disease, it's really critical that we do something called a clinical trial, a randomized clinical trial that compares the drug itself against a group of patients who don't get anything, and then we look at those outcomes objectively, and that's how we'll assess that. I know there's been a lot heard about hydroxychloroquine. I really must, I want to make it perfectly clear that there is no convincing data that hydroxychloroquine or chloroquine is safe and or effective in COVID-19. In fact, many of the trials so far have shown no effect and potentially some harm related to cardiac side effects, heart side effects that are potentially life-threatening in people. So despite what you may have seen on TV and despite all the hoopla on a national level, it is not a safe drug to use. The American College of Physicians has warned against it, and the only time that people should use it is in a randomized controlled trial. So if you're in a hospital and a doctor suggests that you enter a trial, that might be an appropriate setting to use it, but certainly should not be used outside of that setting.
So we've talked about a number of things here. Appreciate your time and expertise, Dr. Hathaway. Do you want to close with any thoughts?
So we've had an opportunity to talk about a lot of different things here this afternoon, from where the illness is in our community, how it's affected some of our most vulnerable people in our nursing homes, what's happened in terms of recent availability of new therapies, a whole host of different conversations. I don't want to end the conversation without reminding people that while we are opening up and while we're moving into phase 2 and hopefully whatever our new normal is here in Western North Carolina in the presence of COVID-19, Now is not the time, despite isolation fatigue and all the challenges that we have with the social distancing, now is not the time to forget the 3 W's. We really, really, really need to be careful and cautious about what we do. We need to wear our masks. Remember, that's a sign of respect for your fellow man. We need to wait 6 feet apart as much as we'd like to be close together, the social creatures that we are, and limit the size of our gatherings. And we need to be attentive to hygiene. Wash our hands, especially after we've touched objects in public places. Now is not the time as we move into phase 2 to forget these 3 W's. And again, I'm forever grateful and appreciative to all that the community has done to keep the curve as flat as it has been so far.
Thank you all for listening today. I hope that we touched on some topics that answered some questions for you. We appreciate you joining us.